Welcome back, everyone. Today I will talk about approach to a child with anemia. Anemia is defined as a reduction of the hemoglobin concentration or red blood cell volume below the range of values occurring in a healthy person. The threshold for defining anemia is hematocrit or hemoglobin at or below the 2 standard deviation for the age and the sex for pediatrics. And anemia is not a disease, but it's an expression of underlying disorder or disease. So when a child is found to have anemia, we should have to search for the underlying disorder, because since anemia is not a disease, it is an expression of underlying disorder or a disease. When we see the values for hematocrit and hemoglobin during the first year of life in healthy term infants, the normal value, it is based on the graph as we have said above, anemias, hemoglobin or hematocrit, which is less than 2 standard deviation below the mean. This is a chart by which we define anemia. When we see classification of anemia, we can classify anemia by different mechanisms. There is etiological classification, morphological classification, and the classification based on severity. When we see classification based on severity, mild anemia is defined as hemoglobin from 9 to 10.9, whereas moderate anemia is hemoglobin between 7 to 8.9, and severe anemia is hemoglobin less than 7 grams per deciliter. And the clinical presentation of anemia is dependent on the severity, the rapidity, and the age of the patient. For example, mild anemia can cause losing stamina, increase in heart rate, and dyspnea with exercise. And this is due to compensatory mechanisms or to anemia by the heart. And pronounced anemia can cause exercise capacity markedly decrement. And in younger individuals, the symptoms and the signs of anemia do not appear until the hemoglobin has fallen below 7 to 8 grams per deciliter, or hematocrit of less than 20 to 25%. When we see pointers toward anemia or clues that gives us the child is having anemia include growth retardation, exercise intolerance, behavioral changes, altered immune response to the disease, and irritability, breath holding spells, and temper tantrum. These are the most common pointers toward anemia. Otherwise, there are so many symptoms of anemia. When we found a child who have anemia, we should have to take appropriate and good history. That includes age of the onset of anemia. Age tells us so many things. For example, if the anemia occurs since neonatal age, it might be due to blood loss, or it might be from hemolytic disorder or inadequate production. And at 6 to 9 weeks of age, physiologic anemia infancy might occur. So if a child or if an infant of 6 to 9 weeks presents with anemia, it might be a physiologic anemia infancy. And rarely nutritional anemia can start very early, especially in preterms. And between 6 months to 2 years, nutritional anemia such as iron deficiency, folate deficiency can occur, and also hemoglobinopathies can present as an anemia. And Fanconi anemia usually present around 4 to 6 years of age. So asking the age of the onset will give us a clue to diagnose the underlying cause of anemia. The other important thing that we should have to ask is about the gender of the patient. For example, X-linked disease will be seen in males only, such as G6PD deficiency and pyruvate kinase deficiency. And in adolescent age, anemia is more common in female due to nutritional deficiency as a result of menstrual loss of iron. And asking about dietary history is also very important, because, for example, if the infant is taking goat milk for a long time, he is at risk for having folate deficiency anemia. If a child is taking a cow milk, that child is at risk for having iron deficiency anemia. And also exclusive breastfeeding for more than 6 months should be supplemented by iron unless we start complementary feeding. The other is, for example, if the child is vegetarian diet, vitamin B12 deficiency is high likely to cause anemia in such child. And also pica, such as eating clay or mud, or geophagia, ice, or phagophagia, or paper, clothes, raw materials, paint flakes, or non-nutritional materials is commonly seen in iron deficiency anemia. And also we should have to ask about onset of the symptoms, and also symptoms of hemolysis such as jaundice, and the urine color change, and also other symptoms of hemolysis should be asked, and also symptoms of bleeding should be asked. And any sign and symptoms of malabsorption should be asked, and also infections and the infestations should be appropriately identified by history. And the drug and the toxin exposure should also be asked. When we see certain drugs that cause anemia and their mechanism, there are certain drugs that cause decreased production due to hypoplasia of bone marrow or bleeding. That means those drugs that cause bone marrow hypoplasia includes chloramphenicol, non-steroidal anti-inflammatory drugs, and the like. The others are drugs that might cause increased distraction. Those includes penicillin and cephalosporin, and also tildopa. Certain drugs can cause also hemolysis. For example, sulfide drugs, especially in G6PD deficiency, mefloquine, quinidine, primaquine. Certain drugs that antagonize folate can cause megaloblastic anemia. For example, anticonvulsantes. And also certain drugs can cause bone marrow suppression. For example, chemotherapy drugs. We should have to also ask about episodic bone or joint pain. For example, if there is certain malignancy that cause anemia, it might also cause, in addition, episodic bone or joint pain. And also asking history of transfusion, asking past blood count, if it's available on the registry is important. And asking for weight loss, fever, and the night sweats, additional symptoms is also important to know the diagnosis. And also asking family history is important, and developmental history, trauma history should be asked. The other thing that we should have to do on a child that is found to be anemic include physical examination. We should have to check for signs of hypovolemia and hypoxia by vital sign by doing pulse rate, blood pressure, and pulse oximetry. And we should have to check for pallor. We should have to check for jaundice. We should have to see for glossitis, stomatitis, and cheilitis, which might suggest a nutritional anemia such as B12 deficiency or iron deficiency. We should have to also check for murmur because in severe murmur there we can diagnose, we might detect flow murmur, and organomegaly can be there, or if the cause of anemia might be due to malignancy and the like. And also we should have to check for skeletal changes and the deformities. We should have to see skin changes. We should have to check for nutritional and neurologic changes. And the other important thing that we should have to is laboratory. We should have to start from complete blood count. From complete blood count, hemoglobin and hematocrit is very important. Hematocrit is the fractional volume of whole blood sample which is occupied by RBC, and it's expressed as a percentage. Whereas hemoglobin is a measure of the concentration of the RBC pigment hemoglobin in a whole blood, and it's expressed as gram per 100 ml or gram per deciliter of whole blood. The other important thing that we should have to see on complete blood count is RBC indices. From that, mean cell volume or MCV is important. The mean value or mean cell volume, which is measured by femtoliter of femtoliters, it is a volume of individual RBC in the blood sample. This mean cell volume accurately detects any general increase such as macrocytosis or any general decrease which is called microcytosis in RBC volume. And this MCV is less sensitive to the presence of a small population of macrocytes or macrocytes. And MCV might be predisposed for error if there is RBC agglutination, if there is distortion on cell shape, if there is a presence of very high number of white blood cells when we do CBC, and also if there is sudden osmotic swelling. Mean cell volume may not tell us exactly about the size of the RBC. So this is the normal hemoglobin and hematocrit, and also normal MCV for children up to the age of 17 years. And if you don't have this chart, we can use the lowest MCV for children between 1 to 10 years as 70 plus age of the child, and the maximum as 100. So for example, if you don't have this chart at hand, the lowest MCV for 2 years old child is 70 plus 2 or 72. For 8 years old child is 70 plus age of the child or 78. Whereas the maximum one is 100. The other important component of RBC indices is the MCH. This MCH is calculated by dividing hemoglobin level by red blood cell count, and this is an excellent measure of the amount of hemoglobin in each individual red blood cell. And MCH is the average concentration of hemoglobin in gram per deciliter. And the value of grams of hemoglobin per 100 ml of RBC is MCHC. This MCHC is used to classify RBC as normochromic if MCHC is between 33 to 34, and we call it hypochromic if it is less than 32, and hyperchromic if it is greater than 35 gram per deciliter. The other important component of RBC in disease is RDW. RDW is the ratio of the width of the red blood cell distribution curve at one standard deviation divided by the MCV, whereas RDW-HD is independent of the MCV, and the RDW-HD is a direct measure of the red blood cell distribution width taken at the 20% frequency level. This is a mathematical representation of anisocytosis. That means this is a mathematical representation of the variation in red blood cell size. The other important thing that we should have to check on CBC is WBC count and the platelet changes. For example, leukocytosis suggests an infectious etiology, or it might tell us about the presence of acute leukemia. And thrombocytosis is a common finding in iron deficiency. And thrombocytosis commonly occurs as a part of acute phase reaction in response to infectious and other inflammatory conditions. And also leukopenia, neutropenia, and thrombocytopenia may tell us about abnormal bone marrow function, or it may tell us increased peripheral destruction of blood cells. The other important thing that we should have to calculate is Menzer index. Menzer index is defined as mean corpuscular volume divided by the first digit of the red blood cell count. If it is less than 13, it tells us about the presence of hemoglobin defect, whereas if it is greater than 13, it suggests iron deficiency. Because in iron deficiency, the RBC count is decreased, whereas in hemoglobin defects such as thalassemia, RBC count is normal. This is an example of how to calculate Menzer index. For example, if a 5-year-old black child presents with a pallor and MCV 64 and the RBC count is 5.3 times 10 to the power of 6, we divided 64 by 5.3 and it becomes 12, and this is less than 13, so this suggests thalassemia. And the other is if a 2-year-old child presents with MCV of 72 and RBC count of 4.8 times 10 to the power of 6, 72 divided by 4.8 is 15. This is greater than 13, and it suggests iron deficiency. Also commonly used, the Menzer index and other indices used to differentiate iron deficiency from thalassemia are not uniformly reliable. The other important thing that we should have to do is reticulocyte count. This is essential in classifying anemia, and the normal reticulocyte count is 1% with a range of 0.6 to 2%. And distinguishing between patients with a functional normal marrow response to anemia or hypoxia and those with a failed marrow response is done by reticulocyte count. So, if there is a normal marrow response to anemia and hypoxia, there is increased in reticulocyte count. Whereas if the anemia is due to bone marrow failure, reticulocyte count is low despite anemia. This is that interferes with the erythropoietic response, nutrient supply, or erythroid precursor proliferation or maturation causes low reticulocyte count. Absolute reticulocyte count is calculated by percent reticulocytes times red blood cell count in liter, and reticulocyte index is calculated by reticulocyte count times observed hematocrit divided by normal hematocrit of the child at that age times 1 over mu, where mu is a maturational factor of 1 to 3 related to the severity of the anemia. So this mu is 1 if the hematocrit is around 45, and it is 1.5 if it's around 35, it is 2 if it is around 25, and 2.5 if it is around 15. The other important thing that we should have to calculate, we should have to do is peripheral morphology. Peripheral morphology is very important, especially if more than one cell line is affected. On peripheral morphology, a normal RBC has the same diameter as the nucleus of small lymphocytes, and RBC is a biconcave disc with an area of central pallor if normal RBC is there, and the pallor is approximately 1/3 the diameter of cell. More sensitive way to detect small population of macrocytic or macrocytic cells that are missed in the MCV measurement. So, peripheral morphology is the best way to detect small population of macrocytic or macrocytic cells that are missed in the MCV measurement of the CBC. And this is used to detect and tell us anisocytosis and epicytosis presence. And polychromatic macrocytes or polychromasia, this is when the cells that is slightly larger than other RBCs there, and it's grayish blue in color and often lacks the normal biconcave shape. And this represents a young reticulocytes or immature marrow reticulocytes, and that still contain large amount of RNA and ribosomes. And inclusion bodies, or such as nucleated red blood cells or whole jolly bodies, tells us abnormalities in marrow production or splenic function. And also on peripheral morphology, we might see blast cells if it is due to leukemia. And in peripheral morphology, we might also see hypersegmented neutrophils if it is due to folate or vitamin B12 deficiency. This table tells us about abnormal RBC morphology and peripheral morphology and the possible underlying causes. For example, spherocytes might be due to hereditary spherocytosis, and the elliptocytes may be due to hereditary elliptocytosis and the severe iron deficiency sometimes, and also bile cells may be due to G6PD deficiency. Schistocytes may be due to microangiopathic hemolytic anemia, mechanical valve induced damage to the RBC. Boor cell RBC may be due to uremia, liver disease, and the like. And also acanthocytes may be due to beta lipoproteinemia, liver disease, post-splenotomy, and the like. And this is also another table that shows peripheral morphology finding of the RBC and the possible underlying causes. For example, target cells may tell us the presence of thalassemia or post-splenectomy or hemoglobinopathies, whereas teardrop might be due to myelofibrosis or underlying marrow process or infiltrative disease. And stomatocytes may be due to hereditary stomatocytosis and the like. Other tests that we should have to do includes LDH level, bilirubin, Combs test, haptoglobin, serum vitamin B12 and the folate levels, osmotic fragility testing, and ANA, and also iron stain, and the like, based on our history and the physical examination, and also our finding from CBC, peripheral morphology, and retic count. So CBC, peripheral morphology, and retic count with history and the physical examination gives us what further investigation we should have to do to get the underlying. The other investigation that might be needed is iron study. Serum iron level is the amount of iron bound to transferrin, and the total iron binding capacity is the measure of the amount of iron that can be bound by transferrin and the percent of saturation of transferrin. And serum ferritin level is used clinically to evaluate body iron stores. And the serum transferrin receptor level. The other investigations that we might do is bone marrow examination. Bone marrow examination include bone marrow aspiration and the bone marrow biopsy based on our CBC, peripheral morphology, and retic count finding. So those things are not always needed. It might be needed if our finding on CBC, peripheral morphology, and retic count tells us that we should have to do bone marrow examination. So when we came to classification of anemia that we said initially, we can classify the cause of anemia or the type of anemia by relying on the CBC and the reticulocyte index. And anemia might be due to a failure in red blood cell production, or it might be an abnormality in cell maturation, or it might be an increase in red blood destruction. So we can classify anemia initially by MCV level. We can say initially macrocytic, normocytic, and the macrocytic based on the MCV level. Then we combine our MCV finding and the retic count. If a child have low MCV with low retic count, it might be due to iron deficiency anemia, thalassemia, chronic disease, lead poisoning, sideroblastic anemia, copper deficiency, and the like. And low MCV with high retic count includes thalassemia syndromes, hemoglobin C, and hemoglobin E disorders, and the like. And the normal MCV with low retic count include chronic disease, RBC, aplasia, malignancy, hypothyroidism, and the like. And For example, high MCV with low retic count include folate deficiency, B12 deficiency, acquired aplastic anemia, congenital aplastic anemia, and the like. Whereas high MCV with high retic count includes active hemolysis with very elevated retic count or erythropoietic anemia type 1 and this. When we see about management of anemia, since anemia is not a specific disease, rather it is a sign of some underlying abnormality. First, we should have to diagnose the cause. So management of anemia is based on the diagnosis of the underlying cause. Several therapeutic agents given simultaneously can make accurate diagnosis difficult, and it can lead to inappropriate maintenance therapy. So we should not treat anemia without diagnosing the underlying cause, because it affects our investigation, our therapeutic agents, and also it may make it difficult to diagnose, and also it's difficult to know the appropriate maintenance therapy. Regarding screening for anemia, the AAP currently recommends that hemoglobin or hematocrit be checked initially between the ages of 9 to 12 months, and additional screening between the ages of 1 and 5 years in if a patient is at risk. So the screening at 9 to 12 months is recommended for all children, whereas additional screening test at the age of 1 to 5 years is needed if a patient is at risk. When we say about the prognosis depends on the severity and the acuteness with which the anemia develops and the underlying cause of anemia. And the mortality and the morbidity rates vary according to the underlying pathologic process causing the anemia and the degree of severity and also the acuteness of the process. Thank you for your attention.